Welcome to those of you here in person and those of you joining us online. My name is Courtney Kaysen-Mann. I'm an audiologist here at Presbyterian Ear Institute, and this is our 6th session of our audiology series. Today we're going to be focusing on dizziness and the ears. We'll start out by completing a brief overview of our anatomy. Starting at the left side of the screen, we have our outer ear, or the pinna. This is the portion of our ear that we can see. We then have our external auditory canal that leads into our eardrum, or the tympanic membrane. The tympanic membrane attaches to our ossicles. The ossicles are 3 small bones that complete a lever action, which vibrates, sending sound into our cochlea. The cochlea is our hearing organ. The cochlea shares a space with our semicircular canals. I think of the semicircular canals as little roller coaster loops. This is the system that responds to different motions, and also the system that can trigger a sensation of vertigo. This is the area that we're going to be focusing on today. We have 3 semicircular canals: the anterior, horizontal, and posterior canals. Each canal has a different job. The anterior canal provides input for motions such as nodding yes. This could also be something like tilting your head back in the shower to wash your hair or bending over to pick something up. The horizontal canal is responsible for motions like shaking your head no. This could be something like turning your head in the car to make sure that the lane next to you is clear to merge. The posterior canal is responsible for side-to-side motions, like doing a cartwheel or rolling over in bed to sit up. Our semicircular canals are supposed to be crystal-free, but full of a fluid called endolymph. When that fluid excites, it then fills with those crystals, or otoconia, which send a motion signal to our brain. Those motion signals tell our body which direction we're moving. This information, combined with what you see and feel, helps us navigate the physical world. On a deeper level, this is the foundation for our coordination, balance, and movement. When signals start misfiring, we may then experience dizziness, nausea, and vertigo. There is a big misconception that dizziness and vertigo are the same thing, and people often use them interchangeably. Dizziness is a feeling of lightheadedness, unsteadiness, or weakness. Dizziness lasts for seconds or minutes. Dizziness is often caused by dehydration, motion sickness, anxiety, or medication side effects. Vertigo is a true spinning or whirling, as if the world around you is moving. This can last for minutes or hours. True vertigo is often caused by problems in the inner ear. We'll now jump into different disorders that can affect the inner ear and cause different types of dizziness and vertigo. The first diagnosis we'll talk about is called benign paroxysmal positional vertigo, or shorthand BPPV. BPPV occurs when small calcium crystals or otoconia in your inner ear become dislodged and located in the semicircular canals. This displacement can then cause the wrong signals to be sent to your brain. When you change positions, like bending over to tie your shoes, you may then experience a sudden spinning spell. These episodes typically last 30 seconds to 2 minutes. BPPV is very easily treated. It can resolve on its own. Though, if it's a prolonged episode, you may see a provider to have the Epley maneuver completed to help relocate the otoconia to the correct spot. BPPV is diagnosed by having a VNG completed with your provider looking for nystagmus. We're going to talk more about VNGs later in this presentation, but we'll look more at nystagmus now. This video is a clip of a woman who has BPPV. Her vertigo is triggered when she rolls from side to side. Nystagmus is a rapid, involuntary eye movement. In these instances, the nystagmus is beating away from the affected side, or towards the healthier ear. When the provider works with her to relocate her otoconia, her nystagmus will resolve and she'll be able to roll from side to side without a vertigo episode taking place. The next two diagnoses we'll talk about are called vestibular neuritis and labyrinthitis. These both have an acute onset. Vestibular neuritis is an inflammation of the vestibular nerve, which is responsible for our balance and spatial orientation. There is typically a viral trigger, like herpes simplex, which is also responsible for cold sores, or an upper respiratory infection. Though there are times where vestibular neuritis is idiopathic, meaning we don't know what caused it. Symptoms include a sudden onset of vertigo. People with vestibular neuritis are often experiencing such intense vertigo that they have difficulty standing or walking, and they are incredibly nauseous. These episodes often last 1 to 2 days at their worst, and then symptoms start to subside. Diagnosis typically includes a hearing test, a VNG and caloric, again, we'll talk more about these at the end, and may include a CT or MRI, depending on how cautious your provider is. Treatment typically includes rest. You can take an anti-dizziness medication like meclizine or dramamine. Sometimes providers will also recommend a steroid like prednisone to help reduce inflammation of the nerve. Prognosis depends on if the person was left with a vestibular weakness. If there is a weakness and you're still getting vertigo or dizziness spells, your provider can recommend vestibular rehab. This is a special type of PT that helps strengthen the vestibular system and improve your overall quality of life. Labyrinthitis is very similar to vestibular neuritis, though the hearing and balance system are both affected. These people experience a sudden hearing loss alongside their vertigo symptoms. With this diagnosis, time is of the essence. These individuals need to receive steroids ASAP to alleviate the inflammation of the inner ear in an attempt to restore hearing. The sooner steroids are administered, the higher the likelihood is that hearing can be improved. Prognosis for vestibular symptoms is the same as vestibular neuritis. Prognosis for hearing differs from person to person and will be discussed on an individual basis. Vestibular migraine is a type of migraine that primarily affects the balance system, causing dizziness, vertigo, and other balance-related symptoms. The full cause is unknown, but believed to be related to changes in blood flow or neurotransmitter activity. Triggers can include stress, hormonal fluctuations, sleep deprivation, etc. Vestibular migraines are interesting because it doesn't always include migraine headache, and symptoms present differently from person to person. Some people experience true vertigo, while others may have dizziness, lightheadedness, sensitivity to motion, and/or tinnitus. Diagnosis is typically a diagnosis of exclusion. Providers will recommend a VNG and caloric, a hearing test, and sometimes an MRI or a CT, but often the diagnosis is made after things like BPPV and Meniere's are ruled out. Treatment can include meclizine or dramamine for flare-ups and may include triptans to treat migraine symptoms. Treatment may also include trigger avoidance like cutting out caffeine or alcohol and may include vestibular rehab. Prognosis is similar to migraine headaches, with symptoms being chronic but managed with appropriate treatment. Meniere's disease is a disorder that causes episodes of vertigo, tinnitus, hearing loss, and a feeling of pressure or fullness in the ear. The full cause of Meniere's is unknown, but believed to be related to an imbalance of fluid or endolymph in the inner ear. Symptoms typically include vertigo, a low-pitch roaring tinnitus, fluctuating hearing loss that can affect one or both ears, and aural pressure. Diagnosis includes a hearing test, VNG and caloric, and an MRI or CT. Treatment typically includes anti-dizziness medications like meclizine for flare-ups, diuretics or steroids to help reduce fluid buildup and inflammation, lifestyle changes such as reducing sodium intake, avoiding caffeine and alcohol, and keeping a regular exercise and sleep schedule. In extreme cases, a neurotologist or a specialized ENT may perform a surgery to drain excess fluid from the affected parts of the ear, though this often leaves the person without hearing on the side that was operated on. Meniere's is chronic and does not ever fully go away, but management can lead to periods of remission. Acoustic neuromas are non-cancerous, slow-growing tumors that form along the branches of the cochlear nerve. The most common cause of acoustic neuromas is neurofibromatosis type 2, though roughly 95% form without any specific cause. Interestingly, true vertigo is an extremely uncommon symptom with acoustic neuromas. Most symptoms include unsteadiness, drifting towards the side of the tumor, and sometimes increased falls. Diagnosis of an acoustic neuroma cannot be made without an MRI. Symptoms do often show up on a hearing test, often in the form of an asymmetric hearing loss with poorer word understanding on the side with the tumor. Treatment includes tumor removal, gamma knife, or a targeted radiation to slow or stop the growth of the tumor, and often just observation with annual MRIs. Length of life is not affected by acoustic neuromas, though patients often experience vestibular symptoms, significant changes in hearing, and facial numbness due to the neuroma. Mal-Day debarkment is a neurological disorder that causes the feeling of persistent motion after travel. Often, Mal-Day debarkment is triggered by passive motion, such as a cruise, flight, or long car or train ride. Symptoms include rocking, bobbing, or swaying sensation. Some people experience unsteadiness, anxiety, and brain fog. Mal-Day debarkment often resolves within 24 hours of travel. However, if symptoms last longer, a provider might order a hearing test, a VNG and caloric, or possibly an MRI or CT scan. Treatment is typically anxiety-based, sometimes including medication, and may include vestibular rehab. In extreme cases, brain stimulation therapy may be completed. Enlarged vestibular aqueduct, or EVA, is an anatomical difference that forms in utero while the fetus is developing. Normally, the vestibular aqueduct, a narrow tube that runs from the inner ear deep into the skull and connects to the endolymphatic sac, is less than 1 millimeter across. In individuals with EVA, this aqueduct can measure 1.5 to 8 millimeters across. People with EVA are typically identified with hearing loss first, though they can present with vertigo and balance problems. 5 to 15% of children who present with sensorineural hearing loss are identified with EVA. This diagnosis must be made with an MRI or CT scan, as the diagnosis is dependent on the anatomical difference in the vestibular aqueduct. Balance symptoms with EVA vary widely. Symptoms can include general dizziness and unsteadiness, true vertigo with nystagmus beating towards the stronger side, trouble walking on uneven surfaces, difficulty with rapid head movement, blurry vision, and nausea and vomiting. Individuals who present with these symptoms benefit from vestibular rehab due to vestibular hypofunction. Now we're going to jump into balance testing. Video nystagmography, or VNG testing, is a diagnostic measure that assesses the function of the vestibular system. It involves recording and analyzing eye movements in response to various stimuli. The analysis is looking for nystagmus to determine where the weakness in the system is taking place. A VNG includes 3 parts. During ocular testing, your eyes will follow different dots or flashes while you keep your head still. During positional testing, your healthcare provider will move your head into different positions to see if nystagmus is triggered. During caloric testing, your healthcare provider will send a steady stream of warm or cool air or water into each ear. This testing should cause nystagmus. These different tests will help determine if you have a peripheral or central deficit and if there is an ear that is weaker than the other. Vestibular rehab is a special form of physical therapy that is designed to treat and improve your balance and dizziness symptoms caused by vestibular disorders. Your balance relies on your central nervous system, or your brain, and your sensory system. This includes your vestibular labyrinth in your inner ear, your vision, and your skin, joints, and muscles. Vestibular rehab will help reconnect these systems to provide you with healthier input. Your therapy plan will depend on your specific weaknesses, which are typically identified during your VNG testing and imaging. Habituation exercise is used to treat symptoms of dizziness that are produced because of self-motion and/or produced because of visual stimuli. Gaze stabilization exercises are used to improve control of eye movements so vision can be clear during head movement. This picture here is an example of gaze stabilization. This gentleman holds his thumb out and fixes his eyes on his thumb while he moves his head back and forth. Balance training exercises are used to improve steadiness so that daily activities for self-care, work, and leisure can be performed successfully. Stretching and strengthening are important for confidence during these exercises, so it helps tie everything together. If you're interested in learning more about vestibular rehab, I recommend this article linked here. It walks through different exercises and stages of rehab. Thank you so much for joining us today. It has been a pleasure presenting for you during these past 2 years. Unfortunately, I will be leaving Presbyterian Ear Institute. We do have 2 lovely audiologists starting at PEI this summer, and they will be taking over our audiology series. However, they may change the dates or topics of our upcoming series. Please visit our website and Facebook page for updated information.